Well, I have the privilege of introducing Jesslyn McMahon. A little background on Jesslyn. After completing undergraduate, she worked in the surgical ICU at St. Luke's for 7 years, and then on to and then during that time to grad school. And after completing grad school, became an acute care nurse practitioner with the critical care team, where she worked at St. Luke's for 2 years. And then wonderfully, and to our team's great benefit, Jesslyn transitioned to palliative care last year. We are thrilled to have you, Jesslyn, on our team, and take it away.
Okay. All right. So my kind of purpose today and what I'll be talking about is my transitioning perspective. So as Maureen mentioned, my background was heavily critical care from both a nursing perspective as well as a critical care provider perspective, and transitioning that into palliative care, which was always ultimately my goal. It's just the timing worked out, and here I am, and I'm so grateful for it. And I've learned a lot in the last year. I have a lot left to learn, but I wanted to kind of share the perspective that I've had, seeing both sides of the coin at this point up until now. So during the transition, some things we'll talk about is the role transition in general from critical to palliative care and how that's gone and how it's going, and changing the perspective, focusing on the life prolongation perspective with some conversations, certainly, and otherwise, but kind of having this focus in the drive to cure, and then focusing more on caring in the specialized palliative medicine perspective now, as well as some benefits to having this perspective and how I kind of reflect back on my practices from that as well. And as well as the challenges of the transition and kind of some things I've learned and noticed about myself and about practice in general, just having done both roles. So I figured I would do a case study. This is kind of a combination of multiple things I've experienced, to kind of put into one fake patient here to kind of talk about the different perspectives and how I look at these concepts now. So a 60-year-old man admitted for sepsis, history of CKD, diabetes, obesity, and then a bedbound status just after a hospitalization a few years ago. And now he can't walk and lives in a nursing home. Came in with sepsis, worsening renal failure, started altered mental status, intubated, and started on dialysis. At that time, kind of preliminary discussions happening with the ICU team about goals and kind of where we go from here, but focusing mostly on the fact that he's currently intubated and whether or not that can be changed. These goals are going through a decision maker of the POA being a girlfriend, but he has 3 grown children that she relies on to help support her decision making, and he remains a full code. So this patient transferred out of the ICU after being extubated, transitioned to regular dialysis, but still not back to baseline, still not able to have conversations and participate in discussions. So kind of this case from 2 different, perspectives and going through that. And ultimately what ends up happening is palliative care consulted right out of transfer. And then unfortunately, due to him just the mental status and things like that, he ended up being transferred back to the ICU, where intubated again, back on CVVH and back on pressors, just from the overall decline, just because it's going to keep happening, unfortunately. So kind of the 2 perspectives that I see this from. So from a critical care perspective, these conversations happening, right? And I've been there myself where you're thinking, okay, we have a breathing tube in. What happens when these 10 to 14 days are up? And we're talking about getting the breathing tube out. Familiar with these conversations, feeling like you can handle it, right? What can palliative care provide that I cannot? And thinking, I've done these conversations before, I can handle it. I have a designated decision maker. Knowing and managing the medical aspect as well, right? You're in it, you're seeing the changes day to day, you're able to have these calls day to day, and it seems simpler to just do them yourself because you're already, rather than complicating things. And then unfortunately, I was a victim of this myself, considering palliative care only when end of life expected, or, thinking of it as transition out of the ICU to help start talking about what's to happen beyond, rather than getting involved in the ICU because it seems simpler to do it yourself in order to prepare and think ahead, because in that circumstance, maybe even preventing some of these setbacks or some re-escalation of care now that you've made it through the acute phase. So from a palliative care perspective, things that I look at this case now and I see areas that involving palliative care sooner, how could we have helped? I think one of the biggest things that I notice and I see is support for the decision maker. especially in this case when the power of attorney is a girlfriend, but not necessarily the children, yet relies heavily on the children, of course, in order to, avert any conflict. So I think ongoing support for the decision maker, making sure that not only she is supported, but also that the children are involved in understanding as well along the way, so that, you can anticipate this is going to be a long course. He's not going to be more than bedbound. Talking about dialysis outpatient on a bedbound patient, there's so many challenges to think about that are not straightforward, unfortunately, and take some time to process for people that don't see this every day. So support for the decision maker and engaging family early. And then thinking the long-term perspective. And I think one of the things that I didn't necessarily realize at the time is that the long-term perspective starts in the ICU. So many times, and like I said, I'm guilty of this myself, thinking, how do I get them through this acute phase and out of the ICU? And part of you is wondering, can I even do that? Right? Is that even possible? And that's where, you tend to feel like you feel those conversations yourself. But thinking long-term in this case would have been beneficial in an earlier time frame. As soon as extubation is happening, do we want reintubation? How do we feel about resuscitation? Okay, now we're talking about transfer to the floor. We've seen this all play out already. Do we want to go through this again, knowing that's likely going to happen? His mental status still isn't better. Things like that just hadn't really changed or improved in the ICU, and still hoping that it would. But what if it doesn't? Those what if conversations to happen that I think in these cases can genuinely help, maybe even prevent ICU readmission and escalation back up to all those supports, which alleviates suffering for the patient, family, all of that stuff, which we all know very well. And I think when it comes down to it, it's the time. I was kind of looking at some articles to see if my feelings were similar to other critical care providers out there. And the biggest thing I could see in researching it was time. That palliative care can take the time to figure these things out. Where are the challenges? Where does the family need support? What is the patient, who are they? And how does that apply to what's happening right now? So in this case, when you're having the conversations of how do I get them out of the ICU, what is the acute phase, there's a whole other level to it of what comes next. And I know that in the ICU, when that was my whole world, I didn't know. It was so enlightening seeing what comes next. So since transitioning to palliative care, some things that I've learned, and one thing that I genuinely appreciate, is that palliative care is not a mutually exclusive alternative, nor a sequela of failed attempts at life-prolonging measures. We, as a team, can be so beneficial for a whole wide range of outcomes and support along the way. And I know I myself was guilty of, this doesn't look like it's going to go well, let's involve palliative care. Well, we can be involved when you're not sure or sooner, or things like that can really help. The increased communication, patients, families, and one thing I've seen on this side that is genuinely so beneficial is the medical team and staff of communicating that, alleviating some of that moral distress. When we look at a patient and we see this isn't a quality of life that I see as acceptable, are they okay with this? And us taking that time, sitting down and having that conversation, and really getting to the bottom of, I know this doesn't look great to us, but to them, this is still living and they want this. Or on the other hand, they're saying they don't want this anymore. Is this true? And figuring that out and really helping be the voice and the advocate for the patient and patients and families. And I remember in the beginning just being like, I have been thanked so much more in this role than ever in critical care. And it was for taking the time, sitting down, talking to us. It was just genuine appreciation, and it just makes you feel like you're in the right spot for sure. One thing I remember learning is that palliative care is a medical dialect. So in doing my CAPC as a new NP with palliative care, I'm thinking and clicking through, we've got this. I'm like, oh, no, too harsh. Okay, all right. And, just trying to figure out kind of these therapeutic communications, translating this complex information in ways that patients can understand, families can understand. And I think the most important part is spending that time to get to know patient and relating that information back to them. Feeling like you're really making a connection, establishing rapport, taking time, explaining the information in an understandable way, and then hearing what they want as a result of it and what they think of it. And then also maybe setting some limitations ideally as well, going down the line in a therapeutic manner that helps really build trust and rapport and help hopefully have the outcome that is the best in the patient's perspective, given the circumstances. The other thing, the biggest thing that I just didn't see until this was life beyond the ICU, the lifelong impact in the quality of life after one stay in the ICU. I know I did a conference a few years ago and they talked about post-ICU syndrome and just the symptoms, the anxiety, the PTSD, the components that come from an ICU stay that don't disappear as soon as they transfer to the floor. And that can impact multiple things. How is their recovery going to go after that? Would they really want to go through that again, knowing what it was like having done it? And it's so important to have those conversations right after while it's still fresh and while we can still talk about those things. Symptom management is another aspect of this role that I still have so much growth to do in, for sure. But learning how to not only treat things, but focus on, while we're treating these things, how do we make them comfortable? How do we give them a quality while trying to achieve the goals? And I feel like that's empowering to assess and to learn and to see as well. Supporting family as well, because there's as much as the patient is there and they're the ones in the bed or chair, hopefully, the family is right alongside with them and struggling too and challenged as well. And then they're also trying to help plan and support for what comes next. So helping bridge that gap and then helping with recurrent admissions or setbacks. So I also love that, at least with our team, the benefit is if somebody comes back, it's the same team member. And I've seen that benefit of, repeated admissions. And, last time Bob was this way and now Bob is that way. And, this is what he told me then. And I'm seeing this starting to happen now. And then, building that trust and, okay, it's happened. And then just being able to feel that transition is just, it's so much different than being from an ICU perspective where you change shifts and you see people a few days, but you might not see them again, versus having that time and that established relationship has just been so helpful. So complete different perspective and a benefit to palliative care that I didn't see when I was, in critical care. And I do think part of it is I was still getting to learn my role there when I transitioned to here. So a lot more learning left to happen in both roles, wherever life takes me. But I'm just very glad to be where I'm at, because these benefits just feel really great to be able to genuinely help patients in that way. Challenges, as everything comes with challenges, but some challenges I noticed in changing the role is changing the frame of mind and kind of stretching myself to think. So one example is in being a nurse practitioner in school, we did a palliative care practice day. And there were two scenarios. One with a 45-year-old in a heart attack, and I had to tell his wife that we've done everything and he was dying and make him comfort. The other was a daughter asking me whether or not she should do a feeding tube for her dad with dementia. And I remember the one with the 45-year-old and he's imminently dying. That one came naturally. Being in the ICU, unfortunately, it's part of what you do. But as far as a feeding tube, you also just a lot of times just do, right? They need nutrition, you do nutrition, but that long-term perspective, right? Which we all know, right? But I didn't at the time. And I know I did learn more about that as I became a nurse practitioner in critical care, but certainly didn't know as much as I know now being in palliative care about that. So changing the frame of mind from what's happening now and what's going to maybe happen in the coming weeks to what are we anticipating in the weeks, months, years, even if they have that. So just changing that perspective to think ahead was definitely a growth period. The other thing is knowing this limitation specific to the role. As a critical care team, I was the attending team and, the one that would manage the medical things and give the risk benefit medical plan options. I'm giving those, I'm explaining those, I'm helping them understand that too in that role. But as a palliative care provider, I am not diagnosing and managing these things. So I need to collaborate more with the attending and the other consulting providers to make sure the patients are getting that information from someone that they can ask the appropriate questions to. So knowing that line in the beginning of not crossing it, because I don't want to get into a situation where they ask a question that I don't have control over. So knowing that limitation was definitely a boundary. And luckily I was trained by someone who also knew that limitation and could help guide me through that. Thank you, Maureen. And then working with the attending teams as a consulting provider, because once again, as a consultant, I'm not the attending, I'm more making recommendations and showing my perspective and advocating for the patient, certainly, but ultimately I'm not the one that is managing the overall big picture. So it's trying to have the collegiate or the professional collegial relationship with people that it helps also achieve what's needed for the patient. And sometimes that's challenging, offering an alternative perspective to what they're thinking, or a challenging perspective, or presenting a situation that unfortunately sometimes their goals just aren't great and they're not very realistic, but the patients want to see them play out. So that's challenging as well, to try and explain to the team, I hear you, I see the challenges, they do as well, but this is what we've got to do for a little bit. And that's another challenge as well, but something that you learn and you grow from as well, to figure out how to communicate that in ways that's helpful. And then learning a new set of information. All of this is new beyond the ICU. So what does home look like? What are facilities like? What are options with facilities? Hospice, what are options for hospice? Community DNR, ways to get people ready, and then also to prepare for what's to come. Do you want rehospitalization? Do you want these things again? Or if not, how do you prepare for that in the community? So that is a whole aspect of things that I had never learned about, or even the medical florists. They were just a foreign place for me, or a place to go for codes. So it was so enlightening to just see a full spectrum of care, and learning, still ongoing learning, especially as patients come back, and how things succeeded or didn't, and constantly adding that stuff to my practice. So that's kind of my overall perspective. I would not change a thing. I think the critical care aspect was immensely helpful in knowledge and support and resources, and in starting these conversations. But I'm so grateful to be where I'm at and with the team I'm at, and continuing to learn how to take those conversations to the next level. So that's kind of where I'm at right now.
Thanks, Jocelyn. There are a couple of questions that came through. That was really great. And I feel every moment of everything you said. A couple questions came through. Rachel would like to know if you have favorite phrases you utilize in your practice, either to communicate with the healthcare team or with the family, that you have found are useful.
I think one of the ones that is the fighter. And actually this is one that I've adopted from Laura McGartland, so I can't take credit for it myself, but that you are always fighting. We are always fighting with you. It's just a matter of, what are we fighting for? At this point, are we fighting for more time, understanding that there may be challenges and it might be, affecting your quality, but are we fighting for quality in the time that we have left? Mm-hmm. But either way, it is a fight, because you hear that so much in the ICU. They're a fighter, they can get through as you're adding more and more pressors, and there's just nothing that you can do. So kind of helping families cope with that. I think that's one of my go-to ones.
I like that one too. Mm-hmm. Looks like Tom has a question. Any thoughts about curbside consults? And then he has a follow-up on that.
Kind of more like talking about patients then on the side of whether or not we can be beneficial. I think I think that's a great way to learn and to see, right? And get our perspective on, do we think we can help more, or can we empower, are we pretty much there and we can just help guide and resource and empower, that provider, and that works in the ICU or the floor, work and empower the provider to kind of, help them reach their goal. So I think it's a good way to do it, to help learn more and for everyone to grow. Mm-hmm.
Any thoughts on daily follow-up versus needed follow-up for ICU patients? The as needed versus the everyday.
I feel like the as needed ends up a little bit more frequent to being every day in the ICU. But I think as they get more closer to transitioning out, where it's, closer to getting to the floor, or, sorry, I set a timer so I didn't go over. That point where things are getting a little bit more stable, then that backs off to as needed. But I do feel like it ends up being mostly daily in the ICU, or, every couple of days. We just put the breathing tube in. We want to see how this goes. Mm-hmm. But I feel like most of the time I end up getting reached out for a setback or something anyway. So it's a check-in at least every day. Kind of depends. But as they get more stable, less and less.
Right. I agree. I think you can't really go back every day and say, are you sure?
No, definitely not. And first, I always for support, is my support now going to help them cope with what's going to come next? And that's kind of my thought process too. So if I feel like, I know you and I recently worked on a patient where the wife needed a lot of support, and that support now, where we weren't making decisions, I think helped build a relationship for when she did need to make a decision. So everyone is unique.
Awesome. Marty, did you have a observation, question?
Yeah, I've noticed that sometimes there's a really distinct difference between floor consults and ICU consults. Sometimes outside of the ICU, we're asked to completely take over the goals conversations, to make the decisions.
Mhm.
And in the ICU, that's not always the case. In fact, I think oftentimes it's the opposite. I feel like when you ask the question, what can palliative care do that critical care cannot? Most of the time when I talk to staff, they're asking me to supplement their conversation, not to replace it. And so I have the time, the dialect, the expertise to provide sort of this richer narrative to help the critical care team make decisions, give the patient a more understood voice. Even if I'm not making the decision, I
Mhm.
can offer all of this story so that a better decision is able to be made.
Mhm. And I think that kind of goes back to where that helps with the moral distress of the team, because then, they're looking at it thinking this doesn't look great for the patient in the ICU with, all these machines attached. And that helps add the narrative to it and the support behind the decision and why we are where we are. And I think that one thing too is understanding and recognizing how much families and patients need time to process and comprehend and cope if they're able to have that time. And it's us kind of, I think I've heard this from you too. I'm sitting in that lane with you for now.
Mhm. Mhm. There was one more question. Rachel wanted to know thoughts about how to better communicate with the ICU staff about the benefits of palliative care, because that's tricky.
It's so tricky and it's so provider specific. I mean, I tried to navigate that even within the team, and it's everyone's different perspectives of palliative care. And I think it kind of goes back to that statement, and that's where that really resonated with me, the one of us not being mutually exclusive or a sign of failed attempts, because I feel like there are definitely providers that feel that way. So I think it's been more in a case by case scenario where they're like, I don't think there'll be a role. And it's like, let's sit down and talk about that, because these are the things that I will be able to help. And it's just a matter of whether they're open to that conversation. I know, I've seen more growth in our team for sure and being open to it, or in working with patients of their, in situations and before going into family meetings or before going into consults, how can we work together to help? I think the biggest thing is listening and hearing what their thoughts are, hearing where they're thinking that we can or cannot help, and trying to figure out how we redirect that or add to that in order to make it a beneficial consult for everybody. But I'm just hoping we continue to see growth in that for sure.
All right. Well, thank you so much, Teslin. Excellent presentation. And thank you, everybody, for being here. Great talk. And have a great Friday and weekend.
Adios.
Okay.
Bye.
No idea.